Great. As we wait for a few more people to join today, I will go ahead and kick off our Bright Spots webinar. The Boost team is really excited today to highlight our story called Simplicity in Solutions, which is one of our Bright Spot stories from our round 2 that highlights stories of innovation and adaptability. So a little bit about the Boost community. Oh, sorry, before we get to that, a few logistical instructions today. Please, while our presenters are presenting, please stay on mute to limit some background noise while our presenters are sharing their story. Throughout the presentation, please feel free to use the reaction buttons and raise your hand if you have questions. We will be having a Q&A at the end of the webinar to answer any of those outstanding questions, which you can also submit using the chat feature. And my colleague Yvonne will be collecting those so that we can share them with the presenters at the end of the live engagement. So the Boost community is a global community of immunization professionals where we can connect immunization professionals to their peers as well as experts, learn new skills that build capacity and lead through challenging contexts. The Bright Spots series is a storytelling series that shines a light on the work that is happening on the ground from members of our community, as well as other immunization professionals and partners all over the world that will help us learn, adapt, and take action in our communities. So currently we have about 25 stories from over 10 countries that occur at the regional district and facility level. And we are excited to have just recently closed our 3rd round of Bright Spots. So keep an eye out for some more stories coming to you by the end of the year. And we'll be sure to share some links in the chat for you guys to learn more about this series. So today we are excited to highlight the Bright Spot story, Simplicity in Solutions. So to learn a little bit more about this story, I will pass it to Ajay Kumar, the team lead of strategic communications at JSI India, to kick it off. Over to you, Ajay.
Yeah, thanks, Ulrich, and good evening, everyone from India. Good morning or good afternoon from wherever time zones you are. Once again, on the outset, we would like to thank you, Bright Spots, for giving this opportunity, and we are so appreciative about their initiative to find stories from the grassroots level and then kind of disseminate to national, international platforms so that there is no need of reinventing the wheel. So this kind of model is really fantastic, so that policymakers and practitioners in the immunization field are kind of able to understand what's going in a better way across the globe, so that they can replicate or scale up to in their geographies and economies. So economy is very important, as we say, because money is always something which matters, especially during this particular difficult time. So this is very important. That's why we were so happy to submit this story 1 year back, where this is a kind of cost-effective method to monitor routine immunization in those areas where people have less connectivity, internet connectivity. As we know, these days are always counted upon the level of connectivity each and every individual living in this globe is concerned all about. So wherever there are less connectivity and then where the terrain is very difficult, then we chip in with those methods which will address all these, and of course will address it in a cost-effective manner. That is why I think maybe Boost has also selected this for our webinar. And then once again, on behalf of JSI, on behalf of the Immunization Technical Support Unit, and on behalf of the Ministry and India, I would like to thank Boost for having us here to share our experience and the best practices. We have here with us in my panel, we have Dr. Deepak Polpakara. He is the team lead for AEFI in Immunization Technical Support Unit. He'll be briefing us on the concept of ITSU and how this particular policy has been derived around tracking bags. And then we have Dr. Kamlesh Kumar. He's the senior program manager in program implementation unit of Immunization Technical Support Unit. A high intense professional with lots of experience in routine immunization. He himself is a doctor and, of course, a retired army person. Army people never retire. So he is one of our backbone of our office and our organization, Dr. Ajay Kumar. And we have Dr. Hiten, who leads the most creative immunization state in the country, Himachal Pradesh. Very beautiful state, but very difficult geography, disconnected people, and then very less connectivity. And then this is from his state. This particular success story has been selected, and we always find that that would be the best reason why Himachal Pradesh was selected for this particular success story. And then there are a lot of creative stories happening in his state. Dr. Hiten leads the immunization program in his state. He is the state immunization officer. Dr. Hiten is a public health policy maker working with the state government, and he has several years of experience in routine immunization. And in any state, at the state level, then it comes to the state means it's province, and then we have sub-state, which is divided into districts in India. So Mandi is one of the districts where we have documented this particular story. And Dr. Anuradha is a district immunization officer from Mandi districts of Himachal Pradesh. She is with me in this panel. She'll be briefing about this particular success story. And the most important person here would be our auxiliary nurse, ANM, Miss Sandeeba Kumari. Sandeeba ji is there. She is from her village, very far from the rural scape. She's literally disconnected. We are successful in connecting her live in this particular forum, and then she'll be speaking in Hindi, our national language, and then Dr. Anuradha will be translating it for better understanding. And we are happy to have Sandeeba ji as well here. In my team, we have Mr. Amit, who has been he's the senior program manager for communications. He deals with the entire scheme of things here. And then we have Mr. Deepak Kaul, who is supporting us to make all these things happen on a live scenario, and then ensuring that there is no lack of connectivity here. So these are our Indian team. And then from ITSU, we have Dr. Amrita, Satish, Mona, and many other colleagues from JSI joining this particular evening. It's a Diwali night here. Thank you all of us for joining here. Here I would like to welcome everyone who have been showing their interest in this particular initiative. And I welcome Dr. Deepak to offer his comments and then take this discussion ahead. Thank you once again, all of you. Have a wonderful time. Bye-bye.
So thank you, Ajay. Good morning, good afternoon, and good evening to everyone. I'm representing the Immunization Technical Support Unit, which is a project under John Snow India Private Limited. We are providing techno-managerial support to the Ministry of Health and Family Welfare for all immunization activities, including the COVID-19 immunization program. It has mainly three verticals: the program implementation vertical, strategic communication, and the vaccine safety surveillance. So just as Ajay said, we have people who have a lot of experience working in the field and also at state and national levels. And the whole success of the immunization program goes to our frontline workers and the medical officers in the primary health centers, as well as the district immunization officers and the state program managers, especially the frontline workers, because they have not just the immunization program to look after, but they have to track the beneficiaries of all the other programs, such as maternal health programs, the family planning program, and so on. So it's a very difficult task, and the geography is very different in different parts of the country. Himachal Pradesh, it's a very mountainous region. Some of the villages are very far problem. So it is always so necessity being the mother of invention and innovation, we are very happy to present this particular innovation, which is being used very effectively in the field in Himachal Pradesh. So that's all from my side. I'm handing over to Dr. Kamlesh Kumar, who is going to talk about the immunization program in India. So bye. Thanks and bye.
Thank you, sir. Thank you, Dr. Deepak, sir. And good evening from India, and good afternoon and good morning to all other participants who are from other parts of the world. I will give slight brief about immunization program in India, how it started and what are the changes and what has been achieved during this immunization program in India. Expanded immunization program that was started in 1974 all over the world, and it was decided in 1977 that it should cater for 6 vaccine preventable diseases, that is diphtheria, tetanus, pertussis, polio, and tuberculosis. And it was aimed that by 1990, this population naturally has to be provided for vaccination against these 6 vaccine preventable diseases. And if you see scenario of India, this expanded program of immunization was started in 1978, and naturally it was in initial phase, it was only restricted to the urban areas, but in 1985 it was expanded, it gained momentum, and then it was expanded as universal immunization program. It was aimed that by 1989 and 90 it should cover all districts of India, and it was covered during that phase also. And if you see at the current scenario in universal immunization program, the vaccination is provided against 12 vaccine preventable diseases. As you see, hepatitis B, meningitis and pneumonitis caused by influenza type B, tuberculosis, diphtheria, pertussis, tetanus, polio, Japanese encephalitis, rotavirus, diarrhea that is caused by rotavirus, and pneumonia, and then measles and rubella. These are the 12 diseases against which the vaccination is available in India, and that is free to all population in India. Next, please. If we see the scope and scale of the universal immunization program in India, it is one of the largest public health program in the world. It caters for the annual target of 26.7 million newborns, 29 million pregnant women every year, and these are provided vaccines through 12 million sessions which are planned every year and which are held to provide vaccination. And naturally, for the logistics and vaccine supply, there are approximately 29,000 cold chain points which are there for storage of the vaccine and distribution of the vaccines to the field, that is at the session sites. And as I told, these vaccines are provided against 12 vaccine preventable diseases. 10 out of these are at the means all over India, and 2 are sub-nationally, that is Japanese encephalitis and PCV, pneumococcus conjugate vaccine. Japanese encephalitis is provided in high disease burden states or districts, whichever scenario is there. And PCV, that is being scaled up now. It is now available in 26 states all over India, and that has started, and naturally scaling up it's in the process now. And one more thing, in the universal immunization program, the aim is to produce indigenous vaccines also, and now we know that India is the largest vaccine manufacturer in the world for routine immunization vaccines. Next, please. Then what are the levels of immunization? There are 2 scenarios. One is for rural areas and another for urban areas. This slide mixes both scenarios. In the rural areas, the lowest level of immunization and the place which is catering for the immunization activities, that is subcenter. These subcenters, they are at the population of about 5,000 population in plain areas, and then about 3,000 population for the hilly areas or difficult terrain areas. And in urban areas, naturally, urban health posts are there, or the ANM areas, which are divided, the areas which are divided for each ANM. Then there are primary health centers, or in the urban areas, we will see urban primary health centers. The primary health center, that is known as PHC, this caters for 30,000 population in rural areas and 20,000 population in hilly or difficult terrain areas. It means roughly 6 sub-centers are under primary health center in plain areas or urban areas. Then at the next level is block. That is, in some areas there are block PHCs also, and then there is CSC, that is community health center. This caters for 1 lakh population. It means 3 PHCs are under that community health center. Then actually at the district level and at the state level. So this is the immunization structure in India, and the lowest and most important means the link is sub-center, and the sub-center which we are going to discuss in detail, that is which is managed by Sandeepaji. That is a main hub of the activities of immunization and other maternal and neonatal health activities also. Next, please. There are changes, and in the last, I will say 8 or 9 years, so many changes and so many achievement has been done, and the universal immunization program has gained a momentum, and naturally some milestones have also been achieved. First one and most important, that was very difficult, and that has been achieved by India, the great success of all, that is India was declared polio free, that was in 2014. Then maternal and neonatal tetanus elimination, that validation for this was done in 2015. These are the 2 major milestones for public health. Then for the improving coverage, that is full vaccination coverage in India, various campaigns or catch-up sessions or special activities were done. In 2015, this was mission in the Dhanush was started, and the various phases has been done for this under this mission in the Dhanush. These missions are mostly to cater children up to the age of 2 years and pregnant women, so that any left out or missed out children are provided vaccine, so that full immunization coverage is achieved. Then in the next phase, this mission in the Dhanush was more intensified in 2017, and this was known as intensified mission in the Dhanush. And the means its policy strategy was changed, and it was more intensified. All other departments were also involved in this, and special focus were given for the high-risk areas or difficult to reach areas. Then there are Gram Swaraj Abhiyan and extended Gram Swaraj Abhiyan. These are the social service provider programs in India, and these special activities for this were provided to the village level. And among this, the mission in the Dhanush was also included to provide the all essential services at the village level. So these are the major steps taken by India to improve immunization coverage. For quality improving, there were various steps have been taken during these periods. There was a National Cold Chain Training Center that was established in Pune, that is in Maharashtra state of India. That this was later converted to National Cold Chain Resource Center. This was to strengthen the cold chain system and naturally for the maintaining the cold chain and technical aspects for the cold chain maintenance. And there was assessment was also done, that is, we will say this is effective vaccine management assessment that was done by UNICEF in 2018, so that the priorities can be set for the redesigning or resetting of the priorities for strengthening the system, that is cold chain system in India, to provide best means that cold chain aspect of cold chain status to the vaccination program. Then there is that EVIN. EVIN is a very important aspect that has been developed, that is Electronic Vaccine Intelligence Network, that has been expanded. This was started in 2015, and that has been expanded to all over India in this phase. This is this IT-based application, and this is mainly this caters for the this cold chain logistics monitoring, as well as live temperature monitoring of the cold chains, so that there is no break of cold chain system at any level up to the level of that cold chain point. Then various trainings and orientations, workshops were conducted for the capacity building of the human resources. There were new vaccines were introduced in India, and in 2015 that was inactivated polio vaccine that was introduced. Then in 2016 rotavirus vaccine was introduced, and in 2017 that measles and rubella. Earlier we were using major containing vaccine, and now it has been included rubella also. The measles rubella vaccine was introduced, and naturally in the later stages pneumococcal conjugate vaccine, that is PCV, was also introduced. In 2018, earlier we were using tetanus toxoid, that TT was being used, but now it has been replaced by TD, that is for tetanus and diphtheria. And in 2019, as I told earlier, that PCV vaccination expansion is going on, and at present 26 states they are providing pneumococcal conjugate vaccine to its beneficiaries. Next, please. These are the major milestones as I discussed earlier, and these are historic points in the public health of India. On 27th March 2014, Southeast Asian region, which comprises of 11 countries in this region, this region was certified, which included India also in these countries. This was certified by WHO as polio-free, and this is major milestone for public health and for such a large country, for such a large population. It was great achievement. And on 14th July 2016, WHO certified India for eliminating maternal and neonatal tetanus. These are the two major milestones, and hope naturally we will be able to control all other diseases also by this program. Next, please. So these are the major achievements or program initiatives by Government of India, and naturally at the highest level also, but at the lowest level in the I will not say lowest level, at the grassroots level also, the innovations have been done to improve routine immunization coverage in the program, and to improve routine immunization coverage in the field. And one such best practice for which we are here today, that was done in Mandi district of the Himachal Pradesh. Naturally, this will be discussed in later part of the stages. And for more about the Himachal Pradesh, as we have already discussed, it is one of the beautiful states of India, and state expanded program on immunization, that SCPIU. Dr. Hiten is there. Naturally, he will take us for further discussion on Himachal Pradesh, and then further discussion on this discussion on that initiatives which have been started by sub-center by Sandeepa Bengi. Over to Dr. Hiten, sir.
So thank you very much. First of all, good evening and good morning and good afternoon, everyone, whoever is listening to me. One of the, as they are saying, I thank first of all Government of India for giving me this chance to interact with so many, a lot of people from a lot of nations have joined today. We belong to a very small state, northern state state in India, which basically consists of 12 districts, and we have a totally difficult topography. We have varied areas where we have a lot of snowbound areas. We have high mountainous areas where, I mean, talking about immunization services, first of all, I would take that bringing the vaccine to that place, bringing it back, and vaccinating the people over there, gathering them. It's a whole different arena over here in our state. We have tried our best to cover everything, each and every child of our state. And luckily, as we are in the state, we have through the NFHS surveys also, if you'll see, we are currently the topmost state for full immunization coverage of 89.2%. So talking about first of all this best practice from northernmost state of India, Himachal Pradesh. This is from the mountainous regions of a village of district Mandi of block Buxad. I have myself been to this block. It's a very difficult area, and the sub-center Sarowa. I really thank our health workers and all who are like working in this such a difficult times, and bringing the vaccine, vaccinating people. I'm really thankful to them, and definitely monitoring is also an aspect of us. Cold chain points, even like Dr. Kamlesh sir said, that even is also being run in all the cold chain points. We are even doing our work to reduce the wastage. Our sessions are planned in such a way that uh, that all the vaccine gets utilized, which is under open vial policy. So we are trying our best to be at the top, but yeah, everywhere network doesn't help us. So we have these innovations which today they will be presenting in details. This is about a health sub center who caters to a population just over 3,000 people. There are small ashas who are working under the female health worker for mobilization of the children on a specific spot. Like I mean, we have session sites, although we have session sites in our institutions, but where we feel that the people can't come, sometimes institutions are far away. So we are even conducting sessions at a panchayat ghar. Panchayat ghar is a place where the lowest village level administrative committees are there, who over there we try to arrange, or in a anganwadi center where children come, we try to arrange over there. uh, can we go to the next slide? So like I mentioned that our full immunization coverage is currently 89.3 in the state of Himachal Pradesh, and if I'm talking about the today's coverage, it is 92.3. I mean, we tried our best to sustain and vaccination during the COVID pandemics also. We didn't shut down our routine immunization sessions because it's very difficult for our children to be catered if a lot of children gets in the backlog. So the state had decided for this. Next slide. So talking about the challenges and barriers, we have very limited connectivity, as I earlier mentioned, because in mountain areas, it's very difficult to have even technology and mobile networks. So tracking without the aid of technology, we started tracking them through these tracking bags. Our MCP cards were our basic weapons through which we could, register, record each and every vaccination in our state. So it was like I said, the immunization registers were very bulky and they were very difficult to take to session sites or outreach areas. So thank to this tracking bags, we had a record of our all our due beneficiaries. For our ashas also, it was easy that they can track of it. They can go to the villages and mobilize the children. So as I earlier also mentioned, in this difficult terrain, it is where technology based management solution may not be a viable monitoring solution. So we have these tracking bags in our state, and which are currently also working on the similar pattern.
Yeah,
Can you go to the
thank
next
you,
slide,
Dr.
please?
Hiten. Yeah, so thank you, Dr. Hiten. Now let us move on to Dr. Anuradha for briefing on the success story of tracking bags implemented in Mandi districts. Over to you, Dr. Anuradha.
Namaste, everyone. I guess this way of greeting would cover all the time zones across the globe. I greet everyone from Mandi in Himachal Pradesh. I am the district immunization officer, and I've been looking after this immunization in District Mandi since 2015. Can we go back 2 slides up to the graph? Yes, thank you so much. No, the next one. Yes. So if we see, we compare the performance of District Mandi against the overall performance of Himachal Pradesh. So you can see that as per NFHS 4, Himachal was doing 69.5% full immunization, whereas Mandi was doing 78.8%. And as per NFHS 5, our full immunization coverage is 94.1%. So I won't say that it is just because of one innovation, that is tracking that. It is a lot of hard work involved by our frontline workers who have been very hardworking, very dedicated, very aware, I must say. And they have the latest knowledge of all the vaccines which are being provided by the government of India. Next slide, please. Yes, so as our SIO sir said, we do have a lot of challenges. Mandi itself is a very, we have, it's a difficult terrain. It's a mixed terrain actually. We have areas which are plain. We have areas which are very difficult and hard to reach. We have areas, which are snowbound during the winters. But despite all these difficulties, routine immunization has been conducted. It has all the planning of sessions has been very regular, and we have. I don't think so. There are many left out children as we track them. So when we talk about connectivity, it's not just the physical connectivity that we are talking about. It's also the poor connectivity in terms of technology. Like we don't have network most of the times in many of the places. So the routine tracking mechanisms, they won't work. So though we have such tracking mechanisms like RCH portal in place, but because if we won't have, if we won't have the network, then it's futile to use all those technologies. So this simple simple innovation of a tracking bag has been very, very useful. We have been using tracking bags since 2016 when the state had procured them and provided it to us across the state. So next slide, please. Yes. A little bit about how the vaccination is being conducted at the grassroots. So as you can see in this slide, we are talking about AAA, which is the backbone of the healthcare delivery in our state. So these AAA, it comprises of ANM, that is the auxiliary nurse midwife, ASHA, accredited social health activist, and Anganwadi workers. So here there is convergence of two ministries, Ministry of Health and Ministry of Women and Child Development. So the ANM and the ASHA, they belong to the Ministry of Health. ANM is a healthcare worker who is providing these vaccines. I mean, she's administering these vaccines and she's overall in charge of a health subcenter. Whereas ASHA, she's a local person. She's been selected from that local village from a population of approximately 800 to 1,000. One ASHA is being selected. She's been specially trained and she is the main mobilizer. She's the main link between the healthcare delivery system and the population she caters to. So if around at a population of around 3,000, if we have one health subcenter and the ANM is in charge, then we have around 3 to 4 ASHAs under that health subcenter. So and the Anganwadi worker, she belongs to the Ministry of Women and Child Development. And for immunization, these are also, they are the mobilizers, the motivators. And one Anganwadi worker is at a population of somewhere around 300 to 500 people. Next slide, please. So what is a tracking bag? As we can see from the picture, a tracking bag, it's a simple bag made up of cloth, which has 14 different pockets. And as you can see from the picture, there is one pocket for each month. And there are 2 extra pockets. One is for those who are left out beneficiaries or who have unfortunately died. And the second, the last pocket is for those who are fully immunized people, beneficiaries, sorry. So how does this system work? We have an MCP card, a mother and child protection card, which has a MCP card is issued to every mother once she becomes pregnant. So she will have a MCP card and a unique identity number, which is being given through the RCH portal. Now, as soon as she delivers, her baby will be registered with another unique ID, and the immunization record will go on this MCP card. For the child immunization, that part, it has 2 other counterfoils. So the main MCP card remains with the mother, and the counterfoils they are removed. One of the counterfoil, it goes to the tracking bag, and the second goes to the ASHA. So the information regarding the immunization status of that particular child, it is being maintained in 3 different sites, with the ASHA worker, with the ANM in the tracking bag, and with the mother. So the detail how this tracking bag is being used, and how what has been the benefit of using this, or how easy or difficult it has been to use this tracking bag, I would now request Sandeepa ji to pitch in. And Sandeepa ji, आपसे मेरी request है अपना mic on करें और tracking bag किस तरह से इस्तेमाल करते हैं उसके बारे में बताएं.
Namaste everyone. जी मैम. ट्रैकिंग बैग के बारे में बताना है. ट्रैकिंग बैग हमारा एक कपड़े का बना हुआ एक बैग है जिसमें 14 पॉकेट होती है, जो हर महीने के लिए 12 पॉकेट बनी होती है. 2 पॉकेट हमारी लेफ्ट आउट और डाइट बेनिफिशियरी के लिए होती है, और 1 पॉकेट लास्ट वाली पॉकेट फुली इम्यूनाइज्ड चिल्ड्रन के लिए होती है. जब उसका 2-1.5 साल का उसका पूरा टीकाकरण हो जाता है तो उसके में हम उसकी काउंटरफाइल डालते हैं. हर एक बैग जैसे सेशन के एंड में, जैसे हमारा सेशन जिस दिन हमारा वैक्सीनेशन होता है उस सेशन के एंड में हम इम्यूनाइजेशन कार्ड में 2 काउंटर फाइल होती है. एक काउंटर फाइल हम ट्रैकिंग बैग में यूज करते हैं, दूसरी काउंटर फाइल हमारी आशा के पास रहती है. आशा उस काउंटर फाइल को हमारे पास तब सबमिट करते हैं जब बच्चा 9 महीने का हो जाता है या 1.5 साल का, उससे उसको इंसेंटिव भी मिलता है. तो एक फायदा हमारा ट्रैकिंग बैग का ये रहता है कि हम ड्यू लिस्ट बनाने के लिए हमारे लिए ईजी रहता है. या फिर कोई या मदर वैक्सीनेशन, जैसे हमारा सेशन होता है जिस दिन अगर कोई मदर या कोई बेनिफिशियरी अपना वैक्सीनेशन कार्ड नहीं लेके आती या इसका उससे वो गुम हो गया होता है, तो हमारे पास उसकी काउंटर फाइल रहती है, तो हम उस बच्चे को इम्यूनाइज कर लेते हैं.
Okay, so I would translate what Sandeepa ji has just explained, how to use this tracking bag. Can we have the next slide, please? Yes. So as you can see, I think in this picture, the real tracking bag can be seen very clearly. So what Sandeepa ji is doing, for I would explain this with an example. For example, in the month of January, we have conducted a session, and now there is one child who has received pentavalent 1, the first dose of pentavalent at an age of 6 weeks. So the next pentavalent will be due, second dose will be due after another month. So what Sandeepa ji will do, she will enter the dose and the date of the January dose and the first dose, sorry, and then she will put this counterfoil in the pocket which has been marked February. So similarly, she will do for other antigens. For example, if in the month of January, there was one child who has received the 3rd dose of pentavalent. So now the next dose, next vaccine which would be due, it would be measles rubella at the month of, at the age of 9 months. So she will put the counterfoil for that child in the pocket marked June. So when she for the next one, when she's planning session for the February, then she just has to take out all these cards which have been put in this pocket, and she will have her due list ready. So this is how this tracking bag is, it works. And in case some child has left this place, the child has moved out, then that counterfoil will be put in this pocket which has been labeled as left or dead. Similarly, if the child has died, then that counterfoil will be put in the pocket marked died. And after the child has completed its immunization, like till 9 months, when the child is fully immunized, then that counterfoil will be put in the fully immunized pocket. So this is how it is working. Another benefit of this is like the ASHA has to be paid incentives once the child the child gets fully immunized. So to verify that the ANM just has to take out the card which has been marked as fully immunized, and she would know how much incentive is due for that particular ASHA. So this is how these MCP cards, the tracking bag has been being made use of. One other use of this is like as I said, the immunization record is there in the counterfoil. So in case any parent happens to lose the original, the real MCP card which the beneficiary was supposed to have, in that case also the entire record will be available with the ANM in this MCP counterfoil, and that another MCP card can be made to replace it. So that is all about this tracking back story. And we have seen that this has been a very simple to use tool, and it doesn't need any kind of network connectivity, and the errors committed are also very less because it's the real card that is being used for tracking. So thank you, and bye, and over to Mr. Ajay.
Yeah, thank you. Thank you, Sandeepa ji and Dr. Anuradha Sharma for brilliantly presenting this particular success story. Shall we go to the next slide, please? Yeah, maybe Dr. Anuradha, would you like to share this particular slide as well? Already, you have already mentioned this. Yeah. Please go ahead.
Yes, I did. But yes, I think it is clear the way that tracking back is being used, or the way we have explained how we are using it, that it has been instrumental in tracking the missed out children. What happens is, suppose in a scenario when a child doesn't turn up for vaccination, all this ANM has to do is that she would come to know from the counterfoil which is left that this particular child has not come. So using that unique ID which she has, she just has to go to her RCH register, which actually is very bulky and difficult to carry, as Dr. Hiten mentioned. So from there, she would know the telephone number or the contact number of the beneficiary, its a guardian or its, the child's mother. And she simply has to call her, or she will have the address. So she can simply tell the ASHA worker of that concerned area that she has to know the reason why this child hasn't turned up. So most of the times these children, they do turn up. There may be some illness, or maybe the child has gone somewhere to a neighboring village or somewhere else. So in that case, only, and they don't miss their vaccination. And we are very fortunate in that, people of Himachal are quite aware. And when it comes to vaccination, I think mothers are very, very particular. I've seen, in my experience, that they may, miss their own antenatal checkups. But when once the child is born, they're very, very particular, that the child should get all the vaccines which are available. So usually what happens is that this MCP card the mother is carrying. So if she has visited some other place, she can go to the sub-center or any, a public health institution there, and she just has to show that card and the child will be vaccinated. The only thing is that when these ANMs are making calls, they can update this information from the telephone. Even our ANMs, what they do is like, I think people have become technologically very aware also. So when they're sitting at home and wherever the connectivity is better, so they happen to call all these mothers, see, you have not turned up for your antenatal checkup or any kind of service delivery or your immunization. And at times they would say, our child already has this vaccine from some other place. So they would say, you send this, you send the picture of that updated immunization card. So once they send them, they are updating this information on the counterfoils as well as the RCH portal. So this is how, people have been working. So, they take care of their children like their own, because, we are planning sessions all across the district. The district has a population of around 11,000 approximately, 11 lakhs, approximately. And we are conducting approximately 620 to 630 sessions across the district. And at times we conduct sessions, though the population may not be, the number of children may not be a very large number. but yet we are conducting sessions because these areas are difficult to reach. So in case, and we cannot, we cannot stick to those norms ki, we need to have some 50 children only, then we are conducting sessions. We are conducting sessions for 20 children as well, because we have that physical connectivity issue also, though there may be, a good network of roads, but at times which practically we see, that the bus times may not coincide with the session timings. So such problems also we face. So in such scenarios, that is how we work. And we have seen there are negligible dropout rates. We have not seen, and the only thing is when an A&M is tracking, when she knows that this particular child has not come and she's calling, that also goes a long way in making motivating the beneficiary, that these children, they are being taken care of, or their immunization is being taken care of. So most of these people, the mothers, they do come, they do turn up for vaccination, even if for any reason not in their own subcenter, then they will go to the nearest healthcare facility wherever it is possible. Another thing that I would like to mention here is, the vaccination or the immunization services are being carried out in public health institutions, and as per the NFHS 5, I think in Mandi district 100% immunization is being done by the public health institutions only, and there is negligible vaccination in private sector. So that is also one thing that we are actually very proud of. Next slide, please. I think okay. So advantages of using the tracking tag, I think it is. I need not go into the detail of this slide because I think we have already talked about this. I guess that's all from us from District Mandi. Thank you.
Yeah, thank you very much, Dr. Anuradha and Sandeepaji. Can we move to the next slide, please? Yeah, this impact has been already discussed, and this is very effective in terms of monitoring routine immunization coverage in the village level. And then it also helps us to understand who have been left out. Can you just, this has already been discussed, and can we go to the final slide, please, Yulrich? Thank you. So here in the image, you will see Sandeepaji holding an MCP card, which is filled, and then this is a shot from her own primary health center where she is working in farthest village in Mandi district. So what we were saying, thank you for listening to us, and then just to conclude our learnings from India, it's all about how we customize certain initiatives in tune with the geography and connectivity. So while the urban narratives are going behind technology, there would be an element of digital disconnect or technology divide, which as far as India is concerned, there are a lot of communities and population who are digitally divided and who are technologically divided as well. So always the government keeps an eye on that, and then take a lot of efforts and energy, and then make very friendly policies to bring that community as well into this particular whichever scheme it is, let it be in a health sector or any rural development or water and sanitation, wherever the sector is, the government of India is much concerned about those communities which are digitally disconnected. So my panel here sits in New Delhi, which is India's capital. Meanwhile, Dr. Hiden sits in his state capital, which is in Himachal Pradesh, Shimla, and Dr. Anuradha sits in the district headquarters in Mandi. And we could see Miss Sandeepaji sitting in her village, which is very far from the district headquarters, and the connectivity is very poor. But then again, we have those methods by which connectivity would be seamless, at least for the technology aspects. So what I'm trying to underline is that every initiative should be customized for that particular region, that particular economy, and that particular geography. So why we are presenting this case is that wherever countries which has such issues, maybe in totality we won't be able to identify such geographies, but if we go into micromanagement, micro assessment of geographies and economies, we would find one community or maybe more who are digitally disconnected, and then these are such solutions which would help us. So many countries had their own good practices, and then this is a platform where we could share. And then I would request any other questions related to this, we are happy to answer those. And then obviously in future also, if you have some questions, you need more to know about this, to scale this up or replicate this particular initiative in your particular country, state or district or any community, you are always welcome. And then we always encourage innovations in this particular area. Now we have already crossed 100 crore doses in COVID vaccine, and then the Prime Minister and the Minister had been underlining the fact that we have been taking along digitally disconnected communities along with us. Otherwise, the COVID vaccine program was 100% technology driven through the web portal called CoWIN. So this is how India has been driving its most important and world's largest COVID vaccine program. And of course, this is one among the largest routine immunization program in the world. Last point which I would like to share is that major innovations shall happen at the grassroots level for small communities, which make a huge impact in terms of its success, and then in terms of ownership, and in terms of touching the lives of the poor. So with that note, I wish you all from India a happy Diwali, and then over to you, Ulrich, for the final comments and wrapping up. Bye-bye. Jai Hind.
Great. Thank you all so much for your time and the amazing presentation. I'm going to open it up for questions. So I encourage all participants, if you have questions for anyone who's presented today on the tracking bag, please throw them in the chat. And we will be sure to take the last few minutes to answer any of those questions. To kick it off, I would like to ask, we know that implementing a new tool can be very challenging at first. So I'm curious if you all have any, or can talk a little bit to the maybe advocacy that you did to get this community signed up to use the tracking bag, if there were any kind of campaigns you ran to educate people on how to find the clinic and get vaccinated using this tool. As you know, like educating the community on maybe when you started implementing the tracking bag. That'd be my question. I don't know who would, Ajay, would you be the right person to ask?
Yeah.
To someone?
Thanks
Perfect.
for that. Thanks for that question, Yuli's wonderful question. So in India, so whenever it comes to service provision of certain services like health or public distribution system, it's all 100% subsidized to a large extent, especially for vaccines and health services. Almost all services are, I don't want to call it free of cost, but it's 100% subsidized. So when it comes to 100% subsidized, there is a behavioral insights from the community that it's all the responsibility of the government. And then there is less advocacy required to promote this particular monitoring mechanism, because it's all about the community and the government to implement whichever effective community based initiative need to be implemented. I won't say that there are issues in certain other programs, but not in, especially in routine immunization. But when it comes to use of MCP card, we have a lot of grassroots level campaigns to promote people use and retain that particular MCP card. At the grassroots level, all pregnant mothers are given this particular MCP card. But the consistency in using those is a key concern as far as at least communications people are concerned, and there are a lot of campaigns which are driven at the national level, district level, state level and district level, and even at the grassroots level people are mobilized and then continuously followed up to retain and maintain and use their MCP card, so that there is a track of which all vaccines are being provided to the mother and the child. I hope I answered your question.
Yes, thank you for sharing. And please, anyone who's on the call, please share your questions in the chat. I don't want to take up all the bandwidth today answering and asking questions for our panelists, but yes, any questions in the chat, please, or feel free to raise your hand too. You are welcome to come off mute and ask your question. Maybe while we wait, I'll ask another one, but I know that a lot of members of our Boost community also live or work in very rural, hard to reach areas. So I'm not sure if anyone had maybe a piece of advice or maybe a key lesson learned from using this tracking bag. I know we touched on a lot at the end there, but maybe for someone specifically who's looking to implement this tool in their context, starting it fresh. I wonder if anyone on your team has any advice for someone on the Boost, as part of the Boost community, who might be looking to use the tracking bag.
Dr. Anuradha, would you like to take this question, please?
What I understand is that you are saying whether this tool can be used for, besides, in addition to immunization, if we can use this tool for something else also. That is what you're asking. Yes, so when we started using this tracking bag, as I say, I could see this is an excellent tracking mechanism. And now, since at the district, I'm not looking just after the immunization, I'm also looking after the maternal health as well. So when I look at this tracking bag, what what strikes me that this can also be used in, tracking the antenatal services which are being provided at the subcenter level. What happens is at the subcenter level, our ANMs, they are trained in basic antenatal care. So by virtue of their training, they should be able to pick the high risk pregnancies at an earliest time, because these are the people who are in touch with the community. They have a population of just around 3,000, and they have around 50 to 60 antenatal, maximum 50 to 60 antenatal mothers at in 1 year registered with them. So to take care of these women, it's not very difficult. And what happens is that initially, since they have to get themselves registered to get any services, so these pregnant women, they come to the health sub-centers, they get themselves registered. What maternal health guidelines say that minimum 4 antenatal checkups are required, 1 in each trimester, and in the last 36 weeks and above, you need to have the last 4th antenatal checkup. What practically happens is, for the first 2 antenatal checkups, since they need to have this TD vaccine, women, they go to the sub-centers because it is easier. They don't have to wait in the queues. But for the subsequent, as the pregnancy advances and they've got their iron folic acid also from the sub-centers. So somewhere we feel that their need from the sub-center, they feel that it is over now. So now they travel to bigger places, like to the civil hospitals, to the district hospitals, to get their sonography done, to get other various investigations done. And they are not going to the sub-center, and the ANM loses track of them. What we feel is that a good antenatal checkup, a clinical checkup done in the 3rd trimester and in the 4th visit, they are of very, very prime importance in picking up high risk pregnancies. So these antenatal visits are not happening. So if similar thing is devised, if we have a counterfoil for the antenatal checkups as well, so these 4 antenatal checkups can be similarly tracked by the ANM, so that even if this lady, she has received her antenatal checkup somewhere else, so the ANM should have the knowledge that this particular woman is suffering from, say, hypertension or diabetes or any other complication of pregnancy. So that is where I think another tracking bag can be useful in maternal health. That is what I feel. Thank you.
Great. Thank you so much for sharing. I am aware of the time, so we're at the top of the hour. So I just want to thank our presenters again for sharing about this Bright Spot story. I am just going to have some follow-up pieces here. So I encourage everyone on the call today to join the Boost community. It is a free member account and you can take advantage of our courses, live engagements, events, etc. We also do have a Boost Telegram channel where we do post regular announcements on future courses, webinars, and you can engage with some other immunization professionals. We also have a learning group for Bright Spot. So if you do end up having any questions about today's presentation, please feel free to post to that learning group and we'll make sure that the presenters get those questions answered for you. We would also like to ask everyone on the call today to take a quick survey to help us improve our future webinars when highlighting our Bright Spot stories. And we also would encourage you, if you do have a story to share, while our third round of Bright Spots is closed, we do have an ongoing initiative called Sparks that will give you the opportunity to share some key challenges you're experiencing or lessons learned. So thank you once again to all of our presenters today. We'll be sure to follow up via email with the recording for today's session, any follow-up resources. And I'll turn it, Ajay, if you have any closing remarks, I'm happy to have you close out for us.
Yeah, thank you, Ulrich, for this particular initiative and then giving us a chance to present our case. And then it's always a pleasure to interact with colleagues and immunization professionals across the globe. And once again, from all of us from ITSU JSI, we wish you good luck and all the best. Happy Diwali. Jai Hind.
Happy
Bye-bye.
Diwali. Have a great
Thank
celebration,
you.
everyone.
You too.
All right.
Bye-bye. Bye-bye.
Bye.
Bye.
Thank you, everyone, for joining.